Hello everyone. Today we have with us Arinze, who is looking into monitoring and evaluation at TB Reach, and also we have Ubeka with us, who is a medical director at Chasi. So this conversation is around TB screening, especially integrated TB screening in Nigeria. So to start with, we just wanted to understand first the need for technology, especially in LMICs, where you are trying to reach the unreachable TB patients. How does that look like? I mean, what is the need there?
So, so in Nigeria, for example, the population is slightly above 200 million, and there's data from 2016 that says we have roughly 300 registered radiologists. So if you do the math, that's about one radiologist to almost a million people, slightly less. So the need for technology is non-negotiable. It's only technology that can bridge the gap between service access and quality services. So I think it's crucial. The question is not about whether there's need for technology. It's actually how do we then roll it out as quickly as possible, because the need is huge, speaking from a Nigerian perspective.
And I'm just going to add to what Dr. Ebuka has said. You know, access is a lot of things.
Yep.
Considering that the number is roughly above 200 million people, now we have challenges with access. So we believe that technology coming in is bridging the gap of access to services. So just like he said, it's a question of how do we get it rolled into the settings, not longer a question of the need. Yeah.
So that makes sense, which brings me to my second point, which is a technology which is as new as artificial intelligence. How has it impacted your TB screening programs? What did the program look like before AI was into the system and after AI is into the system? What kind of impact has it created?
Okay, so I think pre-AI, the challenge around the turnaround time has been an issue, right? Turnaround time, trying to get a screening results, trying to confirm the results and trying to get this persons who have been seen to have TB, put on treatment. It has been an issue.
Right.
Now, but from my experiences, we've seen AI coming in to reduce the turnaround time. Yeah, because we see situations where just in 3 minutes, we could actually have the results to tell us if this person is a presumptive TB case, either to proceed or not to proceed. So it's really has beaten down, the turnaround time to, get results.
I think I agree with that, because you see, health equity is an issue. So those 300 radiologists we mentioned earlier are located in the tertiary hospitals. These are located typically in city centers, big cities, right? But Nigeria is such a diverse country. For some people, getting to those big hospitals, they have to cross a lot of hurdles. Many times they give up along the cascade, right? So, and it results in deaths, missed opportunities, all sorts of things. So you see, but AI bridges entirely. That there's no need to go to any hospital, because it's, again, mobile, and we can go to their very village with first-rate healthcare, if you like. And I think it's so helpful. So think of the time it takes to go from a village to a hospital. You are referred to a higher hospital, and then with the use of AI, that entire gap is bridged. It saves money for the client. It saves lives of the people involved, and many times the breadwinners are preserved, so the family is preserved better. And I think it's so crucial that point of health equity and access to everybody needs to be made.
And I'm just going to add to what he said, considering the cruciating economic conditions we have now, right? So the cost of seeking care is reduced, because instead of them coming, you go to them.
Right.
Yeah.
Makes sense. The program that Chukwuebuka and Arinze are running is really unique in the sense that they are not just looking at active TB screening, but they have combined it with incidental detection of pulmonary issues along with heart failure, right? So we'll dive deeper into those two use cases. To start with, how did this idea came along, and what has AI been able to provide in order to pick cases from an active screening program for TB and redirect them to pulmonologists?
Excellent, thank you. So many times when we go for TB outreaches, we announced in the community if you have a cough that has lasted for a long time, please congregate in so and so place, right? So when we come there, in previous years, you see 100 coughers, 200 coughers, and many times after we screen them, in years gone by, about 10 or 20 might be TB, and the rest you just tell them goodbye.
Right.
We've not given them any help for their cough. Are they still coughing? Yes. Is it important? Yes. Can it take their life? Yes. But is it TB? No. Right? So we were looking for a solution that would be more relevant to the entire pulmonary ecosystem. In other words, what if it's something else and not TB? Right? We grew tired of telling these people, our brothers and sisters, to go home without giving them even a diagnosis.
Right.
You know, I think that was how the idea came up. So when we discovered that Qure had this technology that could do this and then incidentally tell us that, I think it was just a no-brainer. So that was where, for me, the spark came.
Yeah, and I was just going to add that even the wealth of knowledge of literature has actually seen, and the LMICs like Nigeria, the research drive to bridge the gap between screening and early detection for this non-communicable diseases vis-a-vis the ones we have taken close interest in is very low. So seeing that Qure.ai has this technology that could bring our ideas, into the ground goal, it was just, a perfect, place for us.
On the similar lines, I would also like to ask you about the usage of QXR in flagging incidental cases of heart failure and tackling diseases like CBDs and CRDs with more AI, right? So how has that experience been, and any other thoughts on that you would like to share?
The experience has been wonderful. So it came as a surprise to us as well, right? So when we went to a state, and Arinze will know this, Ebonyi State in southeast of Nigeria, every state in Nigeria has a slogan. So for example, Lagos is called Center of Excellence. Niger State is called the Power State. Enugu State is called the Coal City State because they have coal. So Ebonyi State is called the salt of the nation. You know why? They have a lot of salt deposits in their ground, right? So we take this X-ray with QXR, we go to do an outreach in Ebonyi State, and we screen 54 people, and about 30 of them had abnormalities. 10 were suggestive of TB, but over 28 were suggestive of cardiac problems. And it was such a light bulb moment. They have so much salt in their soil, so their food has higher salt content. Their rice, they produce lots of rice, will likely have higher salt content. The water they use has higher salt content. And we should have known that it's linked to NCDs. And you must know that a lot of LMICs are now suffering the dual burden of both infectious and non-communicable diseases. And you see, this is what we find. That many times, even after you've saved them from TB, their heart might stop working and they will still die, making a mockery of the efforts you made in providing TB care. So I think that was one experience and this was the very first outreach we did with the QXR. It was so dramatic. And then we started advocacy with the government, with the Commissioner for Health, and I think Arinze will talk more about that. So then the care.
So the advocacy was really a sugar-coating moment for us, because there was a lot of eye-opening moments. You didn't have to go through the period of waiting to get results, having radiologists do these interpretations. In a split of seconds, we're seeing these things on the screen. And the commissioner was wowed. He was like, okay, we're going to key into this, provide any support you need to reach out to, of course, our target areas were the hardly reached areas. We're going to provide the support, we're going to provide all you need, within our means to ensure that this effort gets to the community that it was designed for.
Makes sense. I think the last part of the conversation that I want to come to is a lot of people think in terms of accuracies for sensitivities and specificities, whether it is 0.95 or 96. But when these accuracies are comparable, what people generally don't get is how much work is required beyond the AI algorithm to make a program successful. Whether it is a platform that is needed to digitalize the entire program, or the after-sales support, the engineering required to fit the AI into an offline machine that can actually go to these devices. So from that angle, I wanted to understand from your experience, firstly from a platform point of view, from a digitalization point of view, what was the need of the program that something like QXR was able to solve for you? Qtrack was able to solve for you.
Okay.
So, like I'm a medical doctor,
Right.
and sometimes I find it funny how people fixate on accuracy.
Right.
They are fiddling with numbers. Is it 0.5? Is it 0.45? Is it 0.6? To the patient, it means very little. I think the weightier issue is the platform that will digitize the entire workflow, automate the algorithms, make it in a manner that can use it in a place like my village where there may not be power.
Exactly.
Be able to use it and run an appreciable number. Because when you come to an outreach and you have 200 people and you can only do 10 exposures, it's a waste, right? So I think the entire platform to operationalize whatever thing technology has brought is even more crucial than fiddling with accuracy number. I mean, we get to accuracy. For example, we now have, with your support, we are now able to get the digital films without the history and send to the radiologist, and I think maybe Arinze will pick up on that more, so that we can now compare the QXR reading with radiology. And so far, we've had a phenomenally high kappa statistics. In other words, the concordance between the AI and the radiologist is always tallying. So for me, I'm more concerned about the platform. The engineering that goes into it. Let's get this out to the people before we deal with accuracy as the numbers keep growing. And for me, I'm not usually fixated on that.
Yeah, I'm just going to pick up on the concordance, right? So we've tried to design a process where the films produced from the Qtrack, right, is circulated around 1, 2, 3 radiologists. So we compare what the QI has given us,
Right.
compare the readings of the first radiologist, and triangulate it with the 3 other radiologists. And you see that they're all on the same line, right? So it's really been groundbreaking. The experience has been top notch to actually see that, okay, even outside of the readings of the radiologist, we could actually have a close to 100% accuracy with respect to the films that have been produced. Yeah.
That brings me to my second point. So my friend at Qure says that his mom makes great food, sometimes even better than the restaurant. But if he has to throw a party to 1,000 people, his mom is not going to be a good choice, right? Because apart from the food, the logistics that you need to manage to serve 1,000 people is a skill in itself, right? So how has that experience been for you with Qure? The support after sales that is required to make such program successful?
For me, that is what stands Qure out in terms of their product support. Their customer service is amazing. That relationship is so crucial, for sustainability of technology, because many times when you deploy technology, 1,000 people, the taste may not be as good as when she's cooking for only me. And I think
and it's just so awesome. Just like he said, that for every walk of the way, the support has been there.
Yeah.
For the start off to this present day, the support has been amazing. And now, I would say the support has been 24/7.
It has.
It has been 24/7 because we have a collaborative WhatsApp group. Collaborative WhatsApp group, where, every single thing we do is shared on the WhatsApp group. So if we needed the guidance, they are there to provide the guidance. Either Chirechi and the in-country team, the HQ team, everybody is there to provide the guidance. And just like Dr. Ebuka has rightly said, if we needed a situation to modify XYZ, they pick it up and just in the slightest turnaround time, the information is modified. I think that's been very, very great. Yeah.
Makes sense. Just for closing thoughts, my last question would be, now that we have a successful program running in Nigeria, what does success in terms of scale looks like for such programs, say, in next 3 to 5 years?
So for me, we've done, I don't know, maybe 5,000, 10,000 films since we started. we're talking about 200 million people. That's a lot of people, right? We need even more things. We need more units. We need more grants. We need the complete workflow sorted.
Right.
So from screening to diagnosis to treatment, we need Qure.ai to be able to now develop, to even monitor treatment
Right.
to the point of treatment completion. And even post-tuberculosis lung disease. I want to predict that in the next 5 to 10 years, there will be lots of mobile X-ray units in the market. And I think Qure is strategically located. You know, as you keep on modifying your algorithms, enriching it, and expanding potentially childhood pneumonia, potentially fractures, potentially all sorts of conditions can then benefit from the Qure system. And I think I see a future in that certainly. The government is willing to partner. As I said, the commissioner in Ebonyi State was very excited to take on the Qure of the people we saw with heart problems, because it takes a long time to treat it and it's not covered by the research grant we obtained.
Yeah.
How about you, Arinze?
Yeah, so I think one of the key areas that comes out big for me is the need for, Qure looking at how they can modify their systems to track monitoring of the non-TB, patients, the NCDs, like the CRDs and the CVDs, because once they are put on treatment, we need to also monitor them over time using the Qure system, right, to see how they fare and all of that. And I'm just going to add that the potential for scalability is very high in Nigeria. It's huge. And the results are there. The evidences are there that, the Qure system is, for me, the get-go to be able to ensure that Nigerians, especially in hardly reached areas, in areas that we, on a split second, don't usually think about when we program, are able to attended to. And of course, we hopefully contribute to, reducing the burden of the double burden of both the communicable and the non-communicable diseases in the country. Yeah.
No, that's great to hear. Thank you, Beka and Arinze, for taking the time to talk
Pleasure,
to us,
pleasure,
and more importantly,
pleasure,
being such excellent collaborators in making healthcare accessible and affordable for all.
Thank you.
It's been a pleasure.
Thank you. Thank you very much.
Cheers.
Yeah, thank you.